trauma-informed care is a process or a way of thinking about the care that we give to people, which there's a very official definition up on the screen, but there are many, many definitions of trauma-informed care. There are as many definitions of trauma-informed care as there are people writing about it and thinking about it and talking about it, and this is just one of those definitions, and it came out of the work of a pioneer in the topic, a nurse pioneer. There are many, many pioneers of trauma-informed care, and Sandra Bloom with the Sanctuary model is probably the pioneer that blazed the trail first, but I'm not positive that she is, but she certainly is one. Kevin Huckshorn, who's a master's prepared nurse, actually took a lot of the work of Sandra Bloom and developed the strategies for the core strategies for reducing restraint and seclusion, and has continued to do a lot of work with regard to trauma-informed care. So this is kind of an all-around definition if you're into defining things, but really it's a way of looking at the work that we do that takes into account the strengths of the person, the trauma history of the person, and provides care in a physically safe way and a psychologically safe way for both the people that we're working with as well as for us, and creates an opportunity for people that have a trauma history, which is most people, to have a renewed self-determination in their lives. And I have heard it said many times that the best restraint is self-restraint. And a lot of the trauma-informed care work comes out of the effort in psychiatric hospital inpatient settings to reduce restraint and seclusion. Now, many of you, probably most of you, don't work in that setting, but you still work with people that are consumers or prosumers of that setting, and you've had to probably receive some of the trauma that even happens to people in those settings. So trauma-informed care came about really in American culture as a way to recognize that sometimes the traditional way of taking care of people, especially inpatient in hospitals, was as damaging as what had already happened to the people. And that took a lot of brave advocates speaking out about the experience of being in an inpatient and being traumatized. And one of those, there are many, too many to mention, but Tanya Kane is one, and in her book, A Call to Arms, in a book called A Call to Arms, the author Rosenberg gives the quotation from Tanya Kane, and she talks about how she spent a lifetime of misery and addiction and mental illness before someone was able to say to her, instead of, "What did you do to get yourself in the hospital?" someone said, "What happened to you, Tanya Kane?" And that was the start of recovery for her, and now she's an outspoken advocate for trauma-informed care. So trauma-informed care is just what probably we always thought and hoped we were doing, but a lot of the time we were missing the mark. So it goes to the definition of trauma, and trauma, this is just one definition. It's a definition that comes out of the DSM, not the most recent one, but the one before that. Traumatic events are sudden, unexpected, and extreme. They usually involve perceived or actual threat to life or limb, I would say. Events that are experienced as out of control and usually involve a perception of horror, terror, or fear. The trauma-informed care model encourages us to treat the process of treating people in a trauma-informed way as our universal precaution, our standard precaution. When you get treatment in a med-surg hospital for a medical diagnosis, you are automatically in the group of people against which we use standard precautions, which is to treat everyone's blood and body fluids as if it is infected with a bug that we wouldn't want to get. And trauma-informed care is a type of standard precaution for treating every single person as if they may have been affected by serious trauma, because the prevalence of trauma is so great that it's 80 to 90% likely that the people that we're working with have been affected, seriously affected by trauma. Just a couple of statistics on the screen. One is the 90% of public mental health clients have been exposed to trauma and have multiple experiences of trauma. And in our city, the public mental health system is the Center for Healthcare Services, university hospitals, psychiatric services, and the state hospital. So that's a lot of care. Do you think that the people being served in that particular public mental health service are any different from the people that we're serving at Laurel Ridge, at Methodist, at Nix, and at Clarity, and in all the private offices of the city? They're no different, right? In fact, they are no different. It's the same people. So I personally think, from 26 years of care, that this statistic out of the public mental health system of our country, which this statistic is repeated in study after study, including some of the most recent ones on PTSD from the military, that it's probably the case, 80 to 90%. And if we go to special populations, such as homeless women with a serious mental illness, or homeless men, or just other areas where people are dealing with a chronic mental illness, we probably see the numbers looking even higher. This specific statistic is 97% of homeless women with a serious mental illness have experienced physical or sexual abuse. In a men's homeless shelter, this number, in men who were participating in a program specifically within the shelter, the number was 66%. And of all the men in that shelter, a fourth of them, 25%, had had a serious physical assault in the last year. So not just talking about early trauma, but also the trauma that comes after. So trauma is prevalent, and one of the most helpful ways of informing my practice has been the Adverse Childhood Experiences Study. So we're going to actually look at a few items from the Adverse Childhood Experiences Study. And any of you are already familiar with this? It was a study actually started in the late 90s by a collaborative of the Centers for Disease Control. They are just the masters of statistical analysis, and they have access to many, many statistics. So the Centers for Disease Control and Kaiser Permanente. So two doctors, one from CDC and one from Kaiser Permanente, worked together, and they looked at information that had been collected as part of routine, preventative, or secondary intervention healthcare. And their findings, they say, provide staggering proof that the health, social, and economic risks that result from childhood trauma are staggering and affect a person's life well into middle age. So before I tell you my opinions about that, I'd like to just show you a little bit of the study. So first of all, there is one thing I left out of your packet that I want to give you, and that is the web address for the study, the work. And it's free. You can actually download the tool that they used, which is the ACE scoring tool, in about 5 languages. It's super easy website to remember. It's just ACE Study, all lowercase, ACESTUDY.org, acestudy.org. So you can get the tool, but the 3 areas of adverse childhood experiences that were measured by the study were abuse, physical, emotional, and sexual abuse, neglect, emotional and physical neglect, and also household dysfunction. So the tool allows for up to a score of 10. And for most people who look at the tool, you could probably, give yourself a score in just a couple of minutes, and 3 would probably be where most people are, if not more. So in the study, the results of the study were somewhat more powerful, first of all by the number of participants in the study, which was well over 17,000, but also the background of those participants. So they were not looking at a really at-risk population. This was a group of mostly white, middle age, 56 was the mean age, 93% high school graduates, almost 40% had college graduation, some college, another 36%. So looking pretty good from the outside group of people. So not a real high-risk group of people like what we are probably dealing with at a lot of our United Way agencies. These people were at Kaiser Permanente, getting health care, and just their overall statistics don't put them looking very at risk. Because I've been thinking about this a lot lately, and my views of it are continuing to evolve. But when you visit astudy.org, you can actually look at about 5 to 10 different specific areas that were measured. And in each of them is an almost one-to-one correlation of the number of adverse childhood experiences to the percentage of behaviors that put a person at risk with their health. So for example, from 0 to 5 adverse childhood experiences are the way that they code. And so for people taking antidepressant medications, for people smoking, for people having early initiation of alcohol, the charts are just direct linear correlation up, creating kind of an overall composite view of the adverse childhood experiences study, that what happens first is adverse childhood experiences, the bottom of the pyramid, the base, and this causes the next thing, which is very logical, social, emotional, and cognitive dysfunction. And that results in the next level of the pyramid, in the bright light, might be hard to see, adoption of unhealthy, risky behaviors, and that leads to disease, disability, chronic medical problems, and that leads to early death. And for those of us taking care of people with a chronic mental illness, we know that we can quantify the early death. Across the nation, it's 25-year early death, 25 years earlier than their peers for people with serious mental illness, chronic mental illness, and in Texas, 29 years because of the per capita dollar spent on mental health care in Texas. So Texas looking worse than even. And this has been known since the 90s, and we have taken action in our culture on this information. And one of the leading ways that we have acted on this information is through the effort to integrate behavioral health care with primary health care. So that is big news. It's happening all across the country, and starting in January of 2014, organizations that choose to be the health home, providing all services that people need in terms of health care, behavioral health care and medical care, primary, secondary, and tertiary care, will be able to actually get an accreditation as a health home. So we haven't been sitting around since the 90s when we first got exposed to the adverse childhood effects study and experiences study and doing nothing. We have been taking action on those findings and recognizing that we need to do something about it. But before you got here today, were you really thinking that people's childhood had to do with whether they have diabetes? Some of you were, and so you were early adopters of a trauma-informed approach. As a psych nurse, I've known for a really long time that people's trauma from childhood would affect their emotional well-being, their adaptation of coping skills, their choices that they would make in terms of relationships, behaviors. But I really did not realize that there would be a correlation to whether they would choose to smoke or not to smoke, to what age they would start with alcohol, whether they would be statistically more likely to pick an alcoholic partner to marry. I just really didn't realize that the physical health of a person in their 50s would be impacted by their childhood trauma experiences. But the ACE study really made that a clear fact of science. It's not an opinion. It's pretty well demonstrated by this research and supported by other pieces of research. So just another look at the ACE study pyramid, same pyramid, but we just see that starting with adverse childhood experiences, then there is a decrease in the ability to trust others, the development of judgment, the development of coping. This then leads to the adaptation of bad health practices, and this can take up to 25 years off the lifespan.